Welcome to the Best Health Radio Show. And I am honestly so honored and excited to have this guest on the show today. And I want to tell you a little bit about him and how this happened. And you know, we live in a world today where it's really hard to know who to believe. Around politics, around vaccines, but especially around hormones. If you ask most urologists for men or gynecologists, is it safe to take testosterone or estrogen? They'll often say no, or they don't believe in hormones as though they're not basic, powerful physiologic signaling molecules. So a few months ago, I was lecturing at the American Symposium on Anti-Aging, and there was another lecture. I like to attend everybody else's talks. So there was Dr. Abraham Morgentaler lecturing on testosterone in men, and I was so struck by his talk. It was one of the best talks I've ever heard, and he put up this slide that I now use in a number of my talks because we're kind of on a similar mission. I'm trying to let people know that hormones are safe, especially even for high-risk women, and he's on a mission to talk about the safety of testosterone and prostate cancer. So one of the slides said, almost everything we've learned in medical school about testosterone and prostate cancer is wrong. So he not only has my father's name, Abraham, but he is a thinker. So let me tell you a little bit about him, and then we'll get him right on the show to talk himself. So he's an international authority on men's health and a pioneer in the treatment of testosterone deficiency in men. I mean, he is truly the deal. His research is credited with reversing the decades-old belief that testosterone therapy is risky for prostate cancer, and he's published over 120 scientific articles on testosterone, prostate cancer, male sexual dysfunction, and male infertility. He went about trying to turn the Titanic away from the iceberg of misinformation, and he did it with his own research, and then he published it in peer review, which is not an easy task to do. I have one study in peer review that I did on dialysis patients, and it took me 3 years just to get that published. He graduated from Harvard College, and then he went to Harvard Medical School. He completed his residency through the Harvard program in urology, and then joined the faculty of Beth Israel Deaconess Medical Center and Harvard Medical School. So we are talking to one of the top health men's experts. He is currently an associate, or I think he's kind of now trying to taking himself a little bit away. That's why I really wanted to get him on the show. You wouldn't believe how many times I had to call his secretary and bother her, almost beg her to get him on the show. And this is a Saturday morning, and he's giving us part of his Saturday morning. He founded the Men's Health Boston Center, which is the first center in the United States to focus on sexual, reproductive, and hormonal health for men, testosterone for men. I mean, he is the international expert, and we've got him on the show today. He earned the recipient of the New Investigator Award in 1994, granted by the American Foundation of Urologic Disease, and his work has appeared in the New England Journal of Medicine. My work did not appear in the New England Journal of Medicine, so that's a big deal. Also in The Lancet, the Journal of the American Medical Association, Cancer, and the American Journal of Medicine. And he is the author of very cool books, which when you go to the show notes, we're going to put links to his books because they're so great. In fact, I was just at somebody's home talking about him, and they had his book. Oh, right. I was talking with Dr. Harris that we had on the show, the regenerative physiatrist, a few weeks ago. And I was saying I was going to get Dr. Morgentaler on the show. And he went, oh, my God, he pulled down his book and said, this is one of my favorite books, because he had been contemplating injecting testosterone into joints, but then he felt like the FDA would really get him. So his books are Why Men Fake It, The Totally Unexpected Truth About Men and Sex. You got to get that book. This has been widely hailed as a groundbreaking exploration of male sexuality. And then he also has other books called Testosterone for Life, Recharge Your Vitality, Sex Drive, Muscle Mass. Muscle is what keeps you young. So he talks a lot about that, and overall health, and the Viagra myth, the surprising impact on love and relationships. So this is a thinker who translates his incredible work published in peer review to everyday circumstances to try and help men and their women feel better, live longer, and dispel the myths of testosterone for prostate cancer and cardiac patients. So welcome to the show, Dr. Morgentaler. And your last name is such a challenge, I'm going to call you maybe Abe or Abraham.
Well, listen, thank you very much. And thank you for that lovely introduction. It's a pleasure to be with you this morning.
Thank you. Can you tell me, can you take us through the path of this testosterone misinformation and where you are today with it?
Sure. The short answer is that, when I came out of my training in 1988, I believed, as everybody else believed, that testosterone was the fuel for prostate cancer. And, what I learned is that high testosterone caused prostate cancer. Low testosterone was protective against getting prostate cancer. And that if a physician was foolish enough to give testosterone to a man with a known or undiagnosed prostate cancer, that cancer would just grow like crazy. And we used phrases like testosterone for prostate cancer is like pouring gasoline on a fire or feeding a hungry tumor. And I believed that. But today, 30 plus years later, what I've come to realize after treating literally thousands of men who had prostate cancer, one way or another, is that almost none of that is true, just as you described in your introduction. And so, the latest thing that I published, and it just came out a couple of weeks ago, is in 22 men with advanced prostate cancer, their results with getting treated with testosterone. We weren't trying to treat their cancer with testosterone. They just were miserable because their testosterone was very low. And they wanted to live well. Some of those men knew that they were going to die eventually of prostate cancer. And they just wanted to live as well as they could. And the old belief, the reason why I'm particularly proud of that paper and that study is that they believed, every one of them had been told by other doctors, I worried that it was also true, was that within days or weeks, if I gave these men testosterone with cancer that's now in their bones, most of them, or in their lymph nodes, that their cancers would progress super quick and that they could die or have terrible complications within days. Like, that's what the fear was. And it turns out it's just not true. And so some of these men, actually, the longest one was on testosterone for 7 years and died of something completely unrelated. Others were on it for 2 to 3 years. So it's just amazing how this whole story has flipped.
When you gave your talk in Miami that I'm so glad I got the opportunity to hear, you went back all the way to how this started with the gentlemen who I think there were several of them that won the Nobel Prize and created this misinformation. Can you take us a little bit through that pathway of how we got the wrong concept about testosterone?
Yeah, sure. So, first of all, let me just give you a shout out, in terms of the work that you're doing around hormones and stuff. Like, I think that what people have just failed to recognize, when I say people, let me rephrase. I think sort of I'm a mainstream medical doctor. Right. I'm like trained at like these fine institutions all the way through. I live in the world. I live in the world of academic medicine, have always done so. I've been on boards of professional societies and all this stuff. And I speak at primary care conferences and where everything is evidence-based, or they want it to be evidence-based. And it's just amazing how I would say that the greatest blind spot in, let's call it mainstream medicine, is actually the importance of hormones for men and for women. It's just an enormous blind spot. It's as if all these doctors, some of whom are brilliant, they're open to many things, but they're not open to hormones. They've just got their heads in the sand. And part of the challenge of dealing with hormone stuff is that resistance, right, amongst our colleagues and oftentimes even our friends who are colleagues. And for men, the prostate cancer story with testosterone has been part of this. It's been a mythology. Let's not call it a myth. It's been bigger than life. It's been considered this foundational concept that whether, what they might say is that whether or not testosterone might help some guys, it's going to cause them to die of prostate cancer, right? Like that's the idea. And so the truth is that if we look at the history of, I want to get to your question and where this all came from. But, when I came out in 1988 out of my training, I hadn't learned a single thing about the use of testosterone in men. My training in medical school and residency was that testosterone was important for prenatally for little boys to develop as boys in utero, that it was the key hormone for boys during puberty, that would, make them into men, if you will. It would virilize them, beard, muscle growth, genital growth, sexuality. I learned that. But the idea that men, and maybe it was mentioned somewhere that, if a man lost his testicles or had a pituitary tumor in his brain, that he might not go through puberty because the body wasn't making testosterone. Or that if it happened to him later in life, he would lose his sexuality. There was sort of a vague understanding of that. But the only people in 1988, when I came out of my training and started my own practice at, on the faculty at Harvard Medical School at Beth Israel, then it was called Beth Israel Hospital, then they merged, now it's Beth Israel Deaconess Medical Center. The only people who were getting testosterone treatment in the United States were those very rare individuals who had really severe issues where their testosterone levels were negligible. So it was people with pituitary tumors, rare, but if they had a big enough or in the right location, they wouldn't make testosterone. A lot of those people wouldn't even go through puberty. Or sometimes they had those tumors, the whole pituitary resected, removed. And so they also lost their ability because the pituitary sends hormones to the testicles, which is actually the place where testosterone is made. And if you don't get that signal from the brain, it doesn't happen. Or the very rare cases where somebody had lost both testicles, usually to cancer, but sometimes to trauma. So they can't make testosterone. So, in a major city like Boston, there might be a handful of those patients. That's it. And there was simply a lack of awareness that you could have a relatively healthy, normal man without those issues, whose testosterone levels had declined for whatever reason. Let's call it aging, if you will, although it can happen to men in their 30s, certainly in 40s, that men could have lower levels of testosterone, no pituitary tumors, have 2 testicles, and have symptoms that are associated with having lower testosterone levels, and that those men might benefit from testosterone treatment. Wasn't known. Or if anybody knew it,
they don't understand testosterone's role in keeping your cognition, with so many people going into dementia and cognitive decline and things like that, which we're seeing an epidemic of.
Absolutely. And so when I came out, there just was almost no testosterone being used, certainly not in the field of urology. The urologists consider themselves the protectors of the prostate.
That's what I was going to ask you. I was dancing last night and my dance partner was saying, you ought to see a urologist for something. And I go, isn't that a men's doctor? I don't know. I don't have a prostate.
No, urologists deal with women too. About 35 to 40% of patients seen by urologists are women. Women can have urologic issues like frequent urination, kidney stones. They can have tumors urologists are surgeons of what we call the genitourinary system. So if somebody has a kidney tumor, it's a urologist that takes it out or treats it. Same with bladder cancer and things like that, which can happen both those can happen in men and women. Yeah. So when women can have, urinary issues like where they leak, that we call it incontinence, when they cough or sneeze and things like that, you tend to see a urologist. So, when I came out of my training and nobody was doing this, it turned out that I started specializing in male infertility and male sexual issues. And this is 1988. And when the guys came in with sexual problems, we didn't have much to treat them with. Viagra wouldn't show up for another 10 years. and what did we have? We had surgery to put in an artificial device in the penis called a penile implant or a penile prosthesis. It wasn't very well known back then. The idea of surgery for most men was out of the question. We had injections so that we can inject medicine in the penis. That wasn't appealing. Both of those are very good treatments, but they just weren't that appealing to many men. But before I went to medical school, I spent 3 years in a laboratory as an undergraduate at Harvard, actually working in a laboratory, working with lizards, these little American chameleons. They're all over.
Of those, right.
Yeah, they're all over Florida. And testosterone guides their sexual behavior. And so if you put a male in a cage with a female and their hormones are okay, the male has this bright colored flap of skin under its neck called a dewlap. And so the dewlap comes out and the head bobs up and down very quickly. I like to joke, it's as if the male is going, yeah, 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 yeah. And the female, if her ovaries are intact, are okay, she'll do this very elegant, stately little push-up that basically says, let's see what you got. I'm sort of around. The male comes closer, the dewlap comes out, he repeats the bobbing thing, and the female does her thing, and they repeat this a few times and they mate. If you castrate the male, and this is true for numerous species, but I was working with these lizards, if you castrate the male and you put in a cage with the male does nothing. He doesn't care. He has no libido. It's all from testosterone. And by libido, we mean sex drive. Just, sort of this urge, this impulse. And the female sometimes will do a little push-up, even if the guy hasn't done anything, kind of like, hey, guy, maybe you didn't see me. I'm over here. And my research it was an amazing project. I was in the lab of this guy named David Cruz, who's a professor at University of Texas, now in Austin, but at the time he was at Harvard. And I just contributed an essay to him about the impact he had on my life. There's a special issue for him in the Journal of Experimental Zoology. And my project that he gave me that took 3 years to complete was to put tiny amounts of testosterone in the brains of these castrated male lizards. Not anywhere in the brain, just in the parts of the brain that we had mapped that clearly looked like they took up testosterone and concentrated it and were presumed to be sexual centers in the brain because it was analogous to other species where we knew that was true. And if I was successful in doing this brain surgery and putting tiny, like incredibly small amounts of hormones in those specific areas of the brain,
we put those males per billion and million. I mean, they're like powerful.
Exactly. We put these males in the cages with the female. They had no testicles. They had no circulating testosterone, but their sexual behavior completely came back. The dewlap would come out, the head would bob up and down. The first time I saw that happen, like I couldn't believe it. It was like, oh my God. And the essence of that story, like the real lesson from that, was that testosterone was necessary and sufficient to regulate the entire range of sexual behavior in these lizards. It was just remarkable. And, so I did that research for 3 years. I went to medical school. I thought I was going to be a researcher. I went through 6 years of urology training, got excited about being a surgeon. It's really urological surgery. And then here I was now out in practice, 1988, specializing in male sexual issues. We didn't have much to offer. And I was just wondering about whether men might be like lizards. And the reason I thought so is, we talk about the deep structures in the human brain. We call it the reptilian brain. And we call it that because in evolutionary terms, it's old and we use the term conserved. And what that means is that many of those functions, even though as we go from reptiles to mammals or birds, whatever, up the evolutionary scale, many of those brain functions are pretty darn similar to what they had been with more primitive, in evolutionary terms, more primitive species. And then we've added on, like, we have a cerebral cortex that is incredible compared to what the reptiles have, but that's the outer part. That deep part of the brain that regulates a lot of things, including sexuality, is conserved, and that's the reptilian brain. So the end of the story is that men really are like lizards. and I gave a few of these guys testosterone. Careful, like I was worried.
So guys that had sexual issues,
yeah,
you were one of the. So you really have put testosterone on the map. And what you're talking about is men with sexual issues. Based on your research, you started to use testosterone replacement to help these sexual issues, right?
Exactly right. And I didn't know any other urologists that were doing it. It wasn't taught to us.
No other urologists. This is the first time that we now have low T centers all over the place, but this was the birth of that, right?
Yes, it was. It was. And it came about really only because I had done research with lizards before. Otherwise, it never would have occurred to me. I mean, there was nothing in medical training at the time that suggested that testosterone might be useful for guys around us.
I don't think you know, but I was a distinguished scholar at an estrogen environmental think tank at Tulane, and I got to work with Dr. Lou Gillet, who's now passed away, unfortunately, and he captured alligators in Lake Apopka, which at the time was polluted. This guy was like a He-Man because he captured alligators and he tied them onto surfboards and he measured their phalluses, and he was able to show that the pollution reduced testosterone and was making them feminized. Unfortunately, he got lymphoma. I had his wife, Elizabeth, an anthropologist, on the show, and we feel that he died from lymphoma from hanging out in Lake Apopka, which is now remediated. But it's the whole idea that testosterone is so necessary to stay male.
Absolutely. That's amazing stuff that's going on, with climate change, pollution. We call them endocrine disruptors, right? It's like changing everything.
More and more younger men are having less and less testosterone. So this isn't just an older man issue.
Well, I just saw a paper by a colleague that suggests that may be true. That testosterone levels are declining.
In Boston, there's been it's a Boston paper. They've been tracking men in Boston. Is that accurate?
Well, that's an older paper that said the same thing. That one's probably 10 years old, but this was brand new. I just saw it the other day out of the University of Miami. So I don't know. But so, just going back to my story. So in 1988, I thought I would try this. The first thing I did, again, I was worried about prostate cancer. But so I just started measuring testosterone levels in these guys with sexual symptoms. And I was surprised at how often they were low. Like nobody had taught me that. Nobody was looking. We didn't normally get testosterone levels. There was no reason to do it. And so they were low. And then I didn't even know how to treat. So I went to this senior endocrinologist who treated some of those guys with pituitary tumors. And I asked her, how do you treat with testosterone? She said, oh, it's easy. You give an injection once a month. And she told me the dose. And so I set up a few guys in a row just to see what it was. And I had a nurse. And she gave these injections once a month to I think it was 3 guys. And at the end of a couple months, they came back to see me on their scheduled appointment. I said, what'd you notice? And they said, oh my God, doctor, it's so good. Not only is my sex drive better and my erections better, but I'm better in ways you never even told me might happen. I said, what do you mean? I said, well, my wife likes me more. She thinks I'm nicer to be around.
It's the lizards.
I have. Well, this was beyond sex. I have more patience for my children. I remember one of these guys said, when I wake up in the morning and I put my legs over the side of the bed and I sit up, I'm optimistic about my day. That hasn't happened to me in decades. It was like, wow. And I wasn't sure if it was could it really be testosterone? Maybe this was a placebo effect. You know, in medical school, we learn a lot about the impact of placebo. These guys knew they were getting something that's often called the male hormone, right? And the thing that convinced me that this was absolutely 100% true was this. All these guys told me that things got better, and they also told me that the effect went away before their next injection. They said, so doctor, it's great for the first couple of weeks after my injection. But remember, they were getting it every 4 weeks, once a month, roughly. And they said, but for the last week or two before my next injection, all my symptoms come back. What's up with that? And I didn't know. And it wasn't until we did blood tests that I discovered that these injections were only lasting about 2 weeks. And so what the guys were saying, and there was no way that these men knew that. So the reason it wasn't a placebo effect is that the men were telling me that they felt great, and it was associated with the time when testosterone was up. And when the testosterone levels fell down again, they didn't know that, but what they noticed was that their symptoms came back. That was real. I said, oh my God, like this is noticeable for them almost on a day-to-day basis or within a couple of days. And that was the beginning. And then I started doing more of it, but the big fear, of course, was prostate cancer.
So, you know, one of the things that I reached out to you with was the story of my best friend's husband, who has been on testosterone replacement. Her brother, in fact, he's in Boston, and he teaches anesthesia at Harvard, and he then became a functional medicine doctor. I dated him years ago. That's how I met my best friend. And her husband got on testosterone replacement, felt incredible, ended up getting prostate cancer, and his doctor said, you have to go off. You have to go off. And in your talk, you explained how actually staying on testosterone replacement can reduce your risk of recurrence. He went off testosterone replacement, and a year later he had a recurrence, and they still won't let him back on there. So this was really hitting home, and this is, of course, hitting many men. Can you talk about that, please?
Yes. So it relates to the question you asked me that I didn't answer from a few minutes ago, which is like, why do we even believe this? So, you know, your listeners or viewers will be shocked to know that there's actually no evidence, zero. No one's ever done a study to show that giving testosterone to somebody like, you know, your friend, actually causes anything bad. It's never been done. And on the contrary, when it has been done, which is still limited numbers of men, and I told you about a few minutes ago about the study that we just published, which is related to that, we don't see much. And where the idea came from is also just, it's shocking to me in terms of how, listen, I think the world of medicine, I think the world, I mean, that's my life, and we have so many brilliant people in the field, but sometimes there are these ideas that become ossified. It's like bone, like you can't move them. And that's what this idea with testosterone and prostate cancer is. So the story starts really with 1941 with a guy named Charles Huggins, who went on to win the Nobel Prize. Prostate cancer is it's the second greatest cause of cancer deaths in men. And until 1941, there was no kind of treatment for it. There was no blood test. You didn't pick it up early. So the only men that would have prostate cancer, it showed up late. And a lot of times the guys would come in because they had pain in their bones from metastases. And there was nothing to do to treat them. They could try steroids and stuff, which were around then, but none of that really worked. You could give them pain medicine and alleviate their pain. And what he did, Charles Huggins from University of Chicago, based on studies he had done in dogs, was he showed in dogs that if he castrated them, removed the testicles, that their prostates shrunk. And so he tried that in men who had bone metastases from prostate cancer. He removed their testicles, and they didn't have the blood test that we use today for prostate cancer called PSA. There was another one that was called acid phosphatase. It's not terribly good. It's why we don't use it anymore. it got replaced by PSA. But when a guy had metastatic disease, the levels were up. And what he showed is that when he castrated these men, the high levels of acid phosphatase came down. Great. What he also wrote in that same paper is he wrote something that gave me palpitations when I read it as a young investigator now treating men with testosterone. He wrote, in every case that we gave testosterone, the acid phosphatase increased. That's the blood test. And the final conclusion of his paper, I will paraphrase the last sentence, it's close to this. It's something like testosterone injections activate prostate cancer. And I remember reading that. And by that time, I had, hundreds and hundreds of men on testosterone. Charles Huggins is the patron saint of urology. He's the only person to ever win a Nobel Prize for work performed in urology. There was a second urologist who got it, but he got it for work as an intern that had to do with, he actually put a wire all the way through his veins up into his heart, and which was the precursor, if you will, or the work that showed you could do cardiac catheterization. But he ended up being a urologist, but that's not what he won the Nobel Prize for. So Charles Huggins, patron saint of urology, whatever he says goes. And 80 years later, we're still doing part of what Huggins suggested, which is we treat men with metastatic prostate cancer, not by removing their testicles anymore, but by depriving their bodies of testosterone with an injection.
This is like an analogous, the Women's Health Initiative, which was a statistical fiasco in July 2002, has been in the consciousness of physicians and women that estrogen drives breast cancer. And this is exactly what you're saying, that Huggins in 1941 said testosterone drives prostate cancer. And both of these are in the consciousness. Fear sells, fear gets ossified, as you just said. It's hard as bone, yet it's not reality.
Correct. Exactly right. And I'm familiar, I don't, my practice was exclusively men, for the last 30 years, but I'm very familiar with the WHI study, as you mentioned it, for related reasons, right? That was big news. And in 2002, men stopped their testosterone because of the fear that we just learned that hormones are dangerous in women, allegedly so. Allegedly. I agree with you, it's not
now
true.
Now with the 19-year reanalysis in San Antonio at the Breast Cancer Symposium, 12 prestigious cancer centers said, oops, we made a mistake, reanalyze this, and hormones protect against breast cancer, but that didn't get headline news or in the consciousness of doctors and patients.
Exactly right. So, the scary stuff always captures the imagination, both for doctors and for the public. So anyway, that was the story with Huggins. And
I didn't know, by the way, that the Women's Health Initiative overshadowed and also influenced male hormones. I didn't know that. That's really interesting and sad, but I didn't realize that overshadowed men too.
Sure. Yeah.
Wow.
I was on, you'll find this interesting. So in public radio, one of the grand dames of public radio was Diane Rehm. And she was out of Washington. And I was on her show a couple of times. And I forget what there was some study that came out, or maybe I had written a paper or something. And I was on sort of talking about beneficial aspects of testosterone. Somebody else was on saying we have to be extremely cautious and all these things. And it was a fair show, and she was just the questioner, and she asked thoughtful questions. But after we were done, she said goodbye to me and the other guest. And she says, personally, I don't think that we should treat anybody with any medicine until it's been tested for over 30 years. And, that's an interesting, so I'll tell you what I find interesting about that, is that no new medicines have ever been introduced that have been tested for 30 years. Right? The way we get around that long-term thing is we test a lot of people generally, and we see if there's any side effects. Look at the vaccines, they've been administered to hundreds of millions of people around the earth.
People are the phase 3 of this.
But we find out they're safe, but we don't have 30 years for almost anything, right? Except hormones. And the reason we have it for hormones is that both in men and women, those hormones are naturally occurring. When in fact, hormones are the most natural treatment that one could ever get.
Hear this, everybody. This is really important.
If you get a medicine for whatever it is, cholesterol, gout, heart stuff, high blood pressure, the body has never seen those molecules before. Those are brand new foreign molecules for the body. That's why
you have to have large randomized trials, because they're foreign molecules, but hormones are endogenous.
Hormones, and when we treat, there are some synthetic estrogens and progesterones that do differ from the naturally occurring ones. I'm sure you have more expertise on that and the impact of that. But testosterone, the active form that all men get, and you can get a whole bunch of different ways of getting testosterone. The active molecule is testosterone. It's the exact same configuration. It's the same molecule as the one we make. It's natural. Not only do we have that and have a history of it, and I have a history of measuring it and looking at populations and what natural levels have to do with health or illness, but we also have it in all these animals that we study, where it also occurs naturally. So this idea that we don't know enough about hormones is actually just a crock of warm stuff.
So can you talk, about, so men are frightened that it's going to cause prostate cancer when they get a diagnosis of prostate cancer. They're taken off of it. They're frightened that it'll worsen heart disease, which is a major killer. And can you talk about the reality? And then down the road, I am going to want you, if you wouldn't mention the saturation index. I was I thought that was amazing in your talk, but I just wanted to highlight that was something I wanted you to touch on later.
So listen, the tradition, so let me just tell you a little bit about the Huggins story. So what it turned out, so that's what I told you what Huggins showed, right? He said, if I remove testosterone or lower it in these men, this blood test goes down. That's a good thing, because high levels are associated with worse disease. And if I give testosterone, it goes up. Therefore, testosterone is bad. So I think it was around 2005. In 2004, I published a review for the New England Journal of Medicine that was shocking to me. I did it together with my fellow Hernani Roden, who's now a prominent urologist in Brazil. And Hernani is a very confident young man. Now he's not as young, but he was a very confident young man. Now he's got a little more maturity to him. And it was the first time I'd ever seen him nervous. We hadn't written the paper yet. We're getting ready to draft it. He's reviewed 100 or more papers. I've reviewed 100 or more papers. We split the work. And he comes to see me and he says, Chief, do you have the papers that show that testosterone is dangerous for prostate cancer? I said, Hernani, I thought you must have them. And it turned out that in a couple of hundred papers that had looked at the issue of testosterone and prostate cancer, we could not find one paper that showed in any compelling way that high naturally occurring levels of testosterone were associated with anything bad with prostate cancer, or that testosterone therapy was associated with it. And yet that statement, that belief, was taught around the world to every medical student. Testosterone causes prostate cancer, associated with worse outcomes like more aggressive cancers, quicker death. That's what everybody was taught. And we could find only evidence to the contrary. No evidence supporting.
Understand how something can get into medical curriculum, into the medical mind of your physician. It could last for decades and it could be completely wrong. So you have to understand why it's important to have conversations like this. I'm so glad you come on the show. That's why I also have my membership where we have lots of agile conversations. This is critical because when you don't have enough, your life, as you just said before, is a different life. When you have enough, you have your life back. Yet many doctors have learned wrong in school or in practice that testosterone is to be feared.
Right. So we published that paper, New England Journal of Medicine, and it was the first paper that basically said, we can't find, there's no there. We can't find it. We didn't say it was wrong.
What year was that?
2004.
2004.
2004. We simply said, we can't find evidence supporting the idea that higher levels of testosterone are associated with worse things with prostate cancer.
That's right. When Dr. Leon Spiroff, who's kind of the iconic gynecologic dude, he had just been publishing, I can't find anything to validate the Women's Health Initiative. There's such a harmonic convergence and synchronicity of the hormones for both genders.
So I had to go back to look up Huggins. Like, what was the story with Huggins? And so when I looked, and back then you couldn't find articles, on the internet, or not older articles. It's hard to believe how our lives have been totally transformed by whatever it is, iPhones and internet. But back then you had to go to this strange building. It was called a library. And I had to go to the basement of this library at Harvard Medical School to find the old article by Huggins from 1941. And they've got articles from the Lancet that go to the 1800s there in these bound volumes. And you have to blow the dust off of these things. And there's the article by Huggins, and I read it carefully. And at first it made me nervous. And then I said to myself, how many guys did he actually treat with testosterone? Remember that he said that everybody I treated with testosterone got that. And it turned out, as I read it carefully, because it's not written the same way that things are today, it's more like stories. He actually only gave testosterone to 3 men.
Right. This is all based
of those 3 men.
This information is based on 3 men, and then you dispelled that.
Well, listen, of those 3 men, he only actually gave results for 2 of them. One of those men had already undergone castration, which today we consider a special case. Like, that's an androgen deprived man, and how they're biochemically going to respond to things is a whole different case. In the end, then, this whole idea that came from Huggins, that testosterone activates prostate cancer, is the source of it all, was based on one guy treated only for 14 days with testosterone, and his curve, in the figure, the levels of his acid phosphatase go up and down before testosterone, go up and down during testosterone, and go up and down after testosterone. It's uninterpretable. It does, even that one guy doesn't show that testosterone was bad for it. And that's what it's based on.
It's hard to believe that men have been deprived of this incredible treatment and brain protective treatment, let alone intimacy and relational treatment, based on the fallacy and such insufficient data. It's mind-boggling. And it makes you want to grind your teeth to powder. Although...
Yeah.
Smile, but it's so aggravating. I have woman after woman come into me and say they ask their gynecologist if they are really a candidate for hormone replacement, and their gynecologist will often say, I don't believe in hormones, or hormones are dangerous. Right. And now what you're saying is the danger that men have been told is based on one man, and the gentleman who did this study got a Nobel Prize for it and really put a shadow over the treatment for men for the next how many decades? That was in 1940.
It's 80 years. It's 80 years.
It's when you gave that talk in Miami. I mean, this is extraordinary. Why isn't this being shouted from the rooftops? Thank you for coming on the show and at least discussing it here.
Well, I'll tell you I'm at a point in my career where one gets a little bit more reflective. I stopped seeing patients a year ago. I still continue with some of my academic work, and I'm doing, a lot of lecturing and keynote lectures and things like that. But I'm enormously proud of the work that I've done. And in many ways, I take comfort in the idea that, more than comfort, I take pride in the idea that there actually are millions of men now being treated with testosterone who wouldn't have been treated if we were still so fearful about the prostate cancer issue.
And because of your work, this is you are the key figure that has helped all this occur. I really appreciate your work.
Well, thank you. You know, it's the truth is that I was the only person working on this for a very long time. And I only did it because of the lizards. and the reason it all came about is because it was clear to me, as and you very nicely summed up a lot of the importance of hormones, including testosterone in men and in women, is that I saw some remarkable changes in my patients. And so there's this balancing act between, okay, you're feeling better now, but is this some pact with the devil? Like, is there some price to pay? Namely prostate cancer or dying from prostate cancer,
right,
that, you know, as a result. And while I was doing this, and I didn't have colleagues who were supporting this. People thought I was nutso. Really, I needed to be.
You're nuts if you talk about hormones. They don't see it as part of the way that your body unfolds.
Well, and especially when I started doing this back then, people thought I was doing something really dangerous, especially in urology, really dangerous about prostate cancer. So in order for me to do it, I had to be super careful about prostate cancer issue. And the first thing I started doing was doing prostate biopsies in men before I gave them testosterone. And the reason I did it was I still believed that testosterone made prostate cancer grow. I had no reason to not doubt it. Huggins, yeah. And we treat people today with metastatic disease by lowering their testosterone. So if lowering testosterone seems beneficial for men with prostate cancer, raising it seems obvious that it must be bad. That's the thinking. And that's part of the reason it persists. So I started doing prostate biopsies just to make sure there wasn't a hidden cancer in these guys before I gave them testosterone. And the old belief, of course, is, as I said earlier, was that high testosterone caused prostate cancer. Low testosterone was supposed to be protective. The belief I learned in my training that eunuchs, men who'd had their testicles removed, never got prostate cancer. It's also not true, but that was what I was taught. and so these men with
not everything they teach in med schools is sacrosanct.
So these men with low testosterone, that I was doing a prostate biopsy, and they had no risk factors. They didn't have an elevated PSA. They didn't have a nodule. I was only biopsying them because I wanted to give them testosterone. And I wanted, as best as I could with medical science, to rule out the presence of a hidden cancer. Those guys should have had a cancer rate of basically zero. But right away, we started finding prostate cancer. And
in which men?
In these men I was doing, so they had low testosterone.
Oh, I see. No. So you took men with low testosterone, you were biopsying their prostate, and you found that in men with low testosterone, they had an unusually high rate of prostate cancer?
Exactly.
Okay.
And that was the opposite of what all the training was.
Gotcha.
We submitted it to the Journal of the American Medical Association, and an editor called me. I've never been called by an editor about a paper before. It's all paperwork.
Right.
And this guy calls me on the phone, and nice guy, David
Which journal
Cooper,
was this now?
And the Journal of the American Medical Association,
JAMA. The JAMA journal. Okay.
And he calls me and he says, your stuff is very interesting. It's the opposite of what we all learned. You have a high rate of cancer in these guys with low testosterone. We were all taught they should have almost no cancer. And we're very interested. But, you only have 50 guys. And listen, if you end up with more patients, maybe you have more already. And the numbers hold up, we'll consider publishing it. So in 1996, they did publish it. We had 77 men, and 11 of them had cancer.
With low testosterone levels, and they had cancer.
And normal PSA, which is normally that's high levels, why we biopsy people.
Right.
And that risk was as great as men who had an elevated PSA, men who were known to be at risk for cancer. So that was 1996. That was the first chink in the armor of this story about high testosterone is dangerous, low testosterone is protective.
Aren't men
The low
today
part,
still treated when they get prostate cancer with they get into androgen depriving states?
absolutely.
It's still this. They're still treated the opposite way that physiology makes sense with what you found.
Well, yes, but let me concede something to Huggins. So Huggins did deserve his Nobel Prize, and he deserved it because it was the first time that anyone had shown that any kind of cancer could be hormonally sensitive. And he went on and he did work with breast cancer, ovarian cancer, endometrial cancer. He was actually a brilliant guy. But just because somebody is right about something important doesn't mean they're right about everything. Mm-hmm. And it was new information for him. And what turned out to be incorrect was that raising testosterone in many of these men would make anything worse. Because androgen deprivation, removing testosterone, is not exactly the opposite of giving testosterone. So most of these men in whom we give testosterone, they already have a substantial amount of testosterone, maybe low, but they still have some. And it turns out that all the action in terms of the influence of testosterone or testosterone-like substances on prostate cancer happens at very low concentrations. And once somebody has a modest amount of testosterone, nothing else will happen. So there is some benefit, and now it's been shown.
What do you mean nothing else will happen? Will you explain?
So nothing. So for example, if we use PSA as a chemical marker,
right?
It turns out that the saturation point, the point is which there's maximal effect on, let's say, prostate cancer cells in the test tube. It turns out that maximal amount happens at about 250 nanograms per deciliter. And normal for your listeners is, let's say, 350 to 1,000. Okay. So if you go from 0 up to 250, that you're going to see a rise in everything about prostate cancer, more growth, more PSA, whatever. Once you hit 250 and you add more, nothing happens. It becomes a plateau. And so there are men who have undergone studies where they got super high levels of testosterone just to see what happens, muscle and things like that. And their PSAs stay flat. But if you go into or out of that very low range, the PSA, which is a marker for the prostate, will either go up or go down. So there's that critical point at very low concentrations, and then it plateaus. And the analogy is, if you have a plant that needs water, if you deprive it of water, it'll shrivel, it'll get smaller. If you give it water, it'll grow. But once that plant has enough water, you could have a garden hose running into it 24 hours a day, and that house plant will never grow to be the size of a sequoia tree. It's been saturated, its ability to use that nutrient, if we can call water a nutrient, or prostate cancer testosterone, it's been satisfied. And it's become saturated is the term we use. And so that's the saturation model that I came up with that explains why raising testosterone in these men does not seem to be a problem, even though lowering it can be helpful for some men with widely advanced prostate cancer.
So there are some cases with widely advanced prostate cancer that lowering it is helpful. Can you talk about, men go to their docs and say, can you measure my testosterone level? And the doc will say, oh, it's 300 and you're fine, you're normal, but the men don't feel great. But some men really feel better when it is higher, but they're deprived of it because their docs say, hey, you're normal, I'm not going to give you any because there's all this misinformation. Can you talk a little bit about that?
Yeah, sure. So, the question is partly what's a normal testosterone level? And then what is the test that we're using anyway? So most of the testosterone that circulates in our bloodstream is attached to a carrier molecule. It's called sex hormone binding globulin. We call it by its abbreviation SHBG usually. And what's important about the part that's attached to this carrier molecule is that it can't get into the cell. It's too big. And so testosterone has to come off of that carrier molecule to be able to get into the cell. And that portion of testosterone is called free testosterone. It's free, it's unattached. And that's what gets into the cells. And when we measure testosterone, we're measuring everything, including all the stuff that's attached to that carrier molecule. And in some people, quite a few people, that SHBG level is quite high. And much of the testosterone then is sort of glommed onto that carrier molecule. So total testosterone, which is the usual test, is an okay test, but it's not a fabulous test. Free testosterone is better. It's measuring what we actually care about. And the other thing, of course, is that what's a normal level? So by and large, the labs have come up with pretty low levels that they call normal. So there's nobody walking around with a testosterone level of 300. Let's say 300 is the number. So most doctors won't treat unless it's well under 300. But 295 then might be called low. 305, they would say, is normal. But remember, the normal range goes up to 1,000.
Right. And most men feel a lot better when it's over 550, but the free is the deal, what can signal the receptor. And can you just make a mention on what's biological testosterone?
Sure. So we call it bioavailable testosterone. So bioavailable testosterone is all the testosterone that is not attached to that SHBG molecule. So some of it is the free and some of it is these weak attachments to other proteins in the blood.
Albumin and things like that. Right?
Exactly. Yeah. So listen, if somebody has symptoms and the symptoms tend to be low sex drive, erection's not working so well, brain fog, mood may be depressed, motivation is down, guys feel tired, they don't really have an explanation for it, they don't have their moxie, their get up and go. Those are most of them. And your level comes back in the lower range of normal. You probably have low levels of free testosterone. Tell your doctor that you need a free testosterone test. But even there, what the lab says is normal. They call too many people who are frankly low. They call too many of them.
Right. They're not normal. Ideal. They're just normal ranges. They're not ideal ranges.
Yeah. So that's a real problem. There are a lot of people who have low levels of testosterone. Their bodies are crying out. And the doctors do the test. If they're not experts, it comes back and it looks like it's a normal result.
There's not a lot of experts on this at all.
And there aren't a lot of experts. And the doctors say, I thought you had it, but your levels look normal. So I can't treat you with that. And,
so Dr. Abe, we're starting to see that estrogen can turn back on brains. Estrogen for women is memory. Testosterone for men is memory. Cognitive decline is now the big C other than cancer that we're all fearful of. I have a number of patients that actually we have to give much higher levels than we ever thought of estrogen, but their brain is turned back on. Do you see that with men that are starting to experience severe cognitive decline, that they actually can reverse that with testosterone replacement?
One of the short answer is, well, let me say it cautiously. So the answer is yes, some people clearly have. They feel sharper, they're more on it. When they've done studies, there are some studies that have shown that some of the cognitive tests are improved with testosterone, but there's an equal number that have shown no benefit. So, here's the thing is that humans are very different biologically, one from another. And so I see guys who have, and there's so many symptoms that are related to low testosterone. So I see some men where they may have mainly sexual symptoms, but their energy and their mood is great. I see other men where their mood and cognition seem bad to them, but sexually they're fine. And the point is, everybody's a little bit different in how it shows up around the low testosterone. Very few people have all the symptoms that we've just gone through. If you have normal cognition, I can't make you better.
But what about the Japanese studies where testosterone levels tamp down ApoE4 gene? And they can help quiet the vulnerability gene to Alzheimer's.
So I don't know that particular study, but I do know there is research about testosterone and Alzheimer's. And for people who are worried about dementia, dementia's, you're right. Dementia is like, for those of us who are living well and are paying attention to our health, and feel robust at a more mature age. A lot of us really worry about like what a shame to be in such great shape and to start getting dementia. Like that's a big fear. Right. There is some evidence, I wouldn't call it conclusive yet, but it's very suggestive that testosterone is actually important to prevent the onset of dementia.
Right. It helps keep the volume of the hippocampus where our memories are consolidated and stored. Is that because estrogen does that in women? And I was reading a number of Japanese studies that suggest that testosterone can help maintain the volume of that really important anatomical place in the brain where memories live.
Yeah. Listen, testosterone works on nerves. It works on nerves. Our brains are nerves. And some centers are more sensitive than others. You know, at the outset, I was telling you about my research with lizards. You know, it's like when, you know, what we did to map out the sexual centers of the brain was actually we injected these lizards with this mild radioactivity. And then the lizards get sacrificed, and we actually looked at the brains. And you put the little slices of the brains on it's called photographic emulsion on a slide that has these things. And wherever there was radioactivity, it shows up as a black dot. And so what we would see is clusters of black dots in certain areas of the brain and less so in others. And those were areas what that meant was that they were uptaking testosterone. There were receptors for the testosterone in those areas. My research was to focus on the ones we thought were involved with sexuality, but there's several others throughout the brain. And the brain, the testosterone is a brain hormone. It's a brain hormone. And it's almost all you need to know in order to start thinking whether or not it might be helpful for things like dementia. The studies that still need to be performed, I don't think that the final judgment is in, but that doesn't mean that it doesn't make sense to be thinking about normalizing or optimizing your hormones if you're worried about something like dementia in your future.
So if a man is diagnosed with prostate cancer and he's on testosterone replacement, or he is diagnosed with a heart condition, what are your recommendations for him to chat with his own doctors about with continuing or discontinuing testosterone replacement?
The heart story is, I don't have any kind words to say about that one. That one's total BS.
Yep.
It's an amazing story. If you have me on again one day, I'll tell you that story. It's amazing how medicine works and how it fails. That was a failure. There was a story in 2014 that testosterone was associated with increased cardiovascular risk. Every single study since then has shown the opposite or no effect. And there was 20 years of data before that made it look like testosterone was actually beneficial in terms of heart disease or cardiovascular issues. So that one's a BS story.
Just one comment. I wrote a book called Sexy Brain because sex steroid hormones are so influential on the brain. And I have an entire chapter on all of this research showing how it became bogus on testosterone, causing more heart issues, and then that being debunked. So if you want to hear the story in a chapter, it's in my book, Sexy Brain, which you can get on Amazon or at drlindseyberkson.com. So
yeah, great. So, the problem with testosterone in men, either with prostate cancer or have a history of cardiovascular risks, is that you're fighting perception in the medical community. And some doctors may be willing to consider it and others not. And this is one of the major challenges that the public is having if they think that they're deficient in testosterone. And I'm sure the equivalent is happening with women and hormones there too. The hard thing is to find a practitioner who is savvy and comfortable about those issues.
So you're saying that if you are on testosterone replacement and you're diagnosed with prostate cancer, it's safe for you to continue, and it might even be more beneficial to reduce recurrence? I mean, is that accurate in your mind? Or can you initiate, if you've had prostate cancer, you're a survivor of it, and you're living longer, can you initiate safely testosterone replacement in your perception and practice?
So I need to be careful because I still need to I can't lose the respect of all my colleagues in academic medicine about saying blanket statements. So let me say this: there are different situations with prostate cancer, and I know we have to stop in a minute. So let me just say there are a couple of situations where I absolutely believe it's safe, and I think that urologists and oncologists have to give up the ghost with this fear of testosterone. If somebody has been treated for their cancer, surgery or radiation, and they appear to have had good success, there is no reason to withhold testosterone. If somebody is on what we call active surveillance, they have what's considered a low-risk prostate cancer. It's unlikely to progress, but they're being watched carefully. The data that we have, and we've treated now, over 100 of these men, is it is perfectly safe to give them testosterone. Their risk of their cancer getting worse is no different than men who didn't get testosterone. We've published a couple of papers on that.
I thought you said there was a protective action of testosterone for recurrence.
Yeah, so right. So there have been a couple of papers. So I sort of said I think it's fine to give it. Will it reduce the risk? There's the biggest paper after radical prostatectomy, the surgery for prostate cancer, comes out of University of California, Irvine. The first author is a guy named Tom Allering. And what he found is that he gave testosterone to a considerable number of the men, and he does a lot of radical prostatectomies. So a big portion got testosterone because they were symptomatic and had low levels. And then there was another group that didn't get it. The recurrence rate in the guys who got testosterone was lower than the guys who never got testosterone. There's another couple of papers like that. In medicine, we like these randomized controlled trials, where everybody starts out the same. It's sort of, they're randomized, either get testosterone or not. We don't have that yet. And we don't have it because until recently, it's been considered unethical. It would be dangerous to give testosterone to men with prostate cancer.
Because my hope is myth that it drives prostate cancer.
Exactly. Right. So my hope is that now there's enough evidence that we'll start seeing some of those, but it'll be years before we get results on that. So yes, there's evidence that it may actually lower the risk. It's not the kind of evidence where I'm comfortable yet saying testosterone definitely lowers the risk, but it actually makes some sense to me that it might. And certainly it's not worse.
Okay, certainly it's not worse. You have to really get this. So can you please, you have been in the space of male hormones, going from lizards to men, decades of research, prestigious, impeccable vitae. Can you give us a list of the symptoms that you've now become comfortable to understand are linked to insufficient testosterone in men, besides fatigue? Just, and maybe even some really unusual ones, because you've worked so often in the field. No one has the experience that you do. So that would be really interesting to hear.
Sure. So, there's two main categories of symptoms. So one is sexual and the other is non-sexual. Sexual, and again, nobody has all of these. Right. Almost no one. So, and even if somebody has sexual symptoms, it doesn't mean they have all of the sexual symptoms, but they include worse erections, more difficulty getting an erection, losing your erection, less desire for sex, fewer ejaculations, more difficulty having an orgasm. When you do have an orgasm, the intensity of the orgasm can be less. And in terms of sort of that sexual feeling when you're touched in the genital region, a lot of guys lose that. The non-sexual symptoms tend to be fatigue. People are tired in ways that they don't seem to understand. They've lost their pep or their energy. They've lost their motivation. Mood can be, some guys feel like they become grumpy old men before their time. They're irritable. They don't have patience. And they can be, frankly, depressed, down and blue and feeling aimless and whatever. That's not to say that testosterone is a treatment for major depression, somebody's suicidal, or they're really thinking of hurting themselves or others. The answer is not testosterone. They need to see a psychiatrist and probably go on something else, antidepressants first. But but that sense of, there are a lot of people walking around and say, do you feel depressed in the sort of the non-technical way? Yeah, I feel down. I feel blue. If they're not suicidal, I'm not saying that is low testosterone, but it must be a consideration. And then we have these things that are objective, things you can sort of measure, like bone density. So men who have low levels of testosterone have osteoporosis or a milder
and we're seeing
form.
more osteoporosis in men. This is on the rise.
Yeah, osteopenia is a milder form that usually or often leads to osteoporosis. People can have anemia. Their red blood cell count is low. I had a young guy in his 40s who, just before he saw me, he'd undergone this evaluation for low red blood cell count. It's called a hematocrit or a hemoglobin. And, a GI source, like losing blood in your stool, for example, in your gut, it can be a cause of that. And he'd undergone, testing where they looked down his throat into his lower intestine. They looked from the bottom up with colonoscopy. They didn't find anything. They said, listen, you seem okay. We don't really know what it is. And he ended up having low testosterone. I treated him. And his hematocrit, the measure we use, became normal. Red blood cells are sensitive to testosterone levels.
I had that happen with a woman. She didn't have blood in her stool, but she had chronic anemia. And when she went on hormone replacement with testosterone was part of it, that improved. Her whole blood picture improved.
So he asked me, he says, doctor, if I'd seen you first, would I have needed those other tests? And the answer is no. So listen, it's just to sort of pull it all together, as you know, and I'm sure your listeners have learned from listening to you, hormones are these molecules that run through our circulation. They have profound effects on us. Testosterone affects so many organs, it's hard to even list them all. Brain, nerves, muscle, fat, bone, genitalia. It just goes on and on and on.
In both genders.
In both genders. And when, speaking more of men, but it affects women too, because women can have testosterone deficiency. When a man has low testosterone, he is a diminished version of himself. And his ability to be the best person possible for himself, for his partner, for everyone around him, happens with treatment of that deficiency. It's not so complicated. And we meaning the medical community, just have not been savvy about this. And so I think the way to, we're looking in medicine at all these fancy new things, right? We have these precision medicine. We have these genetic tests people are looking at. The single most important thing, in my opinion, we could do to improve the health of the US or global population is actually becoming aware of the impact of these hormone deficiencies, whether it's estrogen and progesterone in women with also testosterone deficiency and testosterone deficiency in men, and treating them. We will find a population of individuals who are energized, who feel better about themselves, who are better for the world.
I just love what you said. We live in a country where we're always talking about be the best that you can be. Maybe it's different than how Scandinavia looks at educating their kids, but we talk about that and we don't realize how much hormones are part of that picture. And I love where you said, why doesn't the doc even have hormones as a consideration of an issue of what the patient has? And I just want to share one story. There's a gentleman here in town, actually, who was an orthopedic surgeon, very, very robust practice. And he started feeling like, and they have they have to stand up, they have to be in this gear. It's a demanding job. You have to be very physically fit. And he had a robust practice. And he had a lifestyle with his wife that was because of that practice. And he started to feel like he could not maintain that. And he went from doctor to doctor to doctor. And the point is, nobody had that consideration of testosterone insufficiency possibly being part of this 55-year-old male issue. He closed up his entire practice. He couldn't practice anymore. And a few years later, his wife bumped into functional medicine. She was a nurse. And he discovered he was insufficient in testosterone. He went on testosterone replacement. he became now the man, the best that he could be, but he had no longer had his practice. It was such a story, such an incredible story. He went from doctor to doctor, and none of these great minds had a consideration to measure testosterone. It's not in the medical consciousness, and men are losing out. Women are losing out. I love your work because it's so analogous. It's so analogous, it's crazy. I won the science fair in 8th grade because I gave anabolic hormones. I injected them into chick eggs to see if I could shorten the time in which they birthed the eggs, the chicks hatched. So I was looking at effects of hormones in animals when I was in grammar school, and now it's come up this way. And you started with lizards, I started with eggs. There's such a similar pathway because we want people to understand the power of hormones and to try and diminish the inappropriate fear and not have people miss out on being the best that they can be.
Okay, well, congratulations on the work that you do, and congratulations to your viewers for hearing this perspective from you and from the guests that you bring on. It's been a pleasure to be with you.
Thank you so much. You're one of my heroes. Thank you for all your work, and I hope to have you on again talking about testosterone in the heart. And enjoy the rest of your weekend because you gave us your Saturday morning. And I love that I can say my father was one of my favorite people in my life, so I love that I can say thank you, Abraham.
Great being with you, Lindsay.
Okay. Bye-bye.
Bye now.
Be well.
Bye.